Recording started.
Well, good afternoon, everyone. Welcome to today's Grand Rounds. Today we have Dr. Goist speaking to us on the topic of testosterone. Welcome, Dr. Goist, and thanks for being here.
Thanks, guys, out in space out there. So I'm just I generally choose a topic that I find to be somewhat nebulous, and I wonder about if I'm doing if I'm doing the right thing or if I should be doing something differently. And so low testosterone is one of those things that is on that list, and so we're going to talk about that a bit today. No disclosures regarding today's talk. I wish I did. I have some home remodeling I'd like to get done. But so the quick usual overview is kind of like the Dr. Seuss approach: who you should test, and how you should test, and who you should treat, and how you should treat, and hopefully some other useful information. And so then just some of the things that obviously people may complain to you about with their low testosterone. So these are I have three quick cases that I've seen relatively recently. The first is a 41-year-old guy came to me for a new patient visit. Pretty significant history, as you can see, and he had been treated for low testosterone levels. He said they had no energy at all until he takes his testosterone injections. And he says he feels like he can climb a mountain for 5 days, and then he kind of crashes. And then he was a kind of bad historian. I pressed him further about his history, and he had been getting monthly glucocorticoid injections in his knees, and his prior doctor said he thought that was a waste of time, so he just put him on 40 milligrams of prednisone a day. And he said he can't function without his testosterone. Case 2 is a pretty healthy 76-year-old man who just feels like he's not himself lately and knows that it's his testosterone and wants to be tested. And then the last case is a classic 56-year-old obese middle-aged man, poorly controlled diabetic, very sedentary. He's on the usual medications. It's a very stressful job, but he knows why he can't lose weight because he has low testosterone and he has all the signs. So let's talk a little bit about that. So as far as how good is the evidence, this is the big thing about low testosterone. It's just not very good. As far as the most recent large-scale guidelines from the Endocrine Society in 2010, they have two things. They make a recommendation of strong versus weak, and you can see the quote about strong evidence there, and then the quality of evidence being very low, moderate, or high. And so none of the evidence was considered anything above low quality. Wasn't exactly very glowing, so patients will derive on average more harm than good with a strong recommendation.
All right, trying to mute everybody.
And so the definition, pretty straightforward. I won't bore you with that. So either a decrease in sperm production or testosterone production. Primary, obviously, a disease of the testes. Secondary, it's a disease of the pituitary or the hypothalamus. And then you can have a combined primary or secondary. You might see that in hemochromatosis or alcoholism, sickle cell, thalassemia, and then people who are on chronic steroids. I think when you do the testing, it's always secondary. And so what the recommendations are make this diagnosis, and the quote is only in symptomatic men with unequivocally low testosterone, although we're not entirely sure about at what level symptoms and adverse outcomes occur, but it's likely below 300 nanograms. So we wouldn't be talking about internal medicine, we were talking about screening. So first off, recommendation against routine screening. The Endocrine Society does say, they use this verbiage too in other guidelines they have about case finding. So there's a list there about some patient population you may find a higher incidence of low testosterone that may potentially warrant some testing. And you guys can read those. I won't bore you with them, but a lot of things that we see pretty frequently would be obviously type 2 diabetes, maybe some end-stage renal disease, and then people who are on chronic steroids or opioids. And so the potential signs and symptoms, again, is kind of a list. So this list was compiled from the panelists. This was what they had experienced in their clinics, and they felt like their list, these were the list of people who were more likely to have severe androgen deficiency. And I've starred a few of those, and those were actually from population-based surveys of what people were more likely to come in and complain to, maybe in the general population. So that's reduced sexual desire and activity, decreased erections, and hot flashes.
All right.
That's okay. So there's the big algorithm. We're going to kind of go through this. This is the algorithm from the Endocrine Society, and we'll kind of break this down. So how do you test? So obviously the first thing, like always, is trying to take a good history to eliminate other reasons for people to have the symptoms that they're having. They're obviously very vague, and so, but a lot of times I feel like you can kind of get to the bottom, or at least have a good idea of something else that may be contributing to their symptoms, and maybe can avoid having to check for low testosterone. If you do checking that morning testosterone, they say between 8 and 10 a.m. you can see kind of this diurnal variation. We'll talk about that. So generally highest in the morning around 8 to 10, lowest around 8 p.m. There's some loss of that diurnal variation in old men, but they still recommend checking it in the morning because a substantial percentage of them will still be normal in the afternoon. There's actually a small study of about 70-some men where they checked the effect of recent glucose ingestion prior to testing, and there was 66 men they tested who had normal testosterone, and about 10 or 12 of them actually had low testosterone when they tested after eating. So a substantial amount of people will be affected by glucose ingestion. And then someone's acutely ill or subacutely ill, that can affect the levels as well, so don't test in that situation. The recommendations are just to check the total testosterone. It's really an accurate representation of testosterone in the body. You don't necessarily have to order that entire panel, and we'll talk about some of those products. But the total testosterone represents this free testosterone, and then the protein-bound testosterone. That's either bound to sex hormone-binding globulin or albumin. Very loosely associated to albumin, so they feel like it freely dissociates. If you have identified someone you can test for and they have normal testosterone, you're probably done. And so some of the other things I think that are confusing. So what about free testosterone? So if you watch enough TV, I was watching some golf this weekend, and I realized that I'm almost 40, so I'm far less of a man because I have less free testosterone these days. And so it's really not that terribly useful. It's useful in the setting where you feel like sex hormone binding globulin might be affected. And there's also some talk, and I neglected to call the lab to see if we had the proper assay. There's different assays for free testosterone. Some of them are better than others. Sex hormone binding globulin can be increased most commonly in aging. And so more sex hormone binding globulin binds tightly to testosterone, and so there's maybe less bioavailable testosterone. And then it's decreased in obesity. And so if there's less binding globulin, there's actually less testosterone available as well. Some other things that we see pretty commonly would be glucocorticoids and chronic opioids and diabetes. So we've tested, so we've kind of moved down the algorithm. We found that testosterone was low in that one test, so we repeat it. And so when you repeat it the second time, you can check FSH and LH to look for, to try to determine if it's primary hypogonadism or if it's secondary hypogonadism. In our population, usually secondary. Sometimes there may be some people, infertility or things like that. If you decided to pursue that workup, it might be primary, but a lot of times it's secondary. Give you another chance to rule out secondary, other causes that patients may not have been upfront with initially, maybe how much they're drinking or some other reasons. And so it's considered primary hypogonadism if they have low T and they have an elevated FSH or LH, and secondary if the FSH and LH are low, normal, or normal. I've never checked and gotten test results that are consistent with primary hypogonadism. And so if you look, it's one of some areas of confusion. If you looked at that guideline initially, you say, well, now I'm ordering a brain MRI on everybody who has low testosterone. I found that couldn't be right. And so for people, so when these, pituitary hormones might include things like, TSH and some of those other things you probably routinely check. Iron panel if you're trying to rule out hemochromatosis. And this MRI, so there are some recommended age cutoffs from some groups that say maybe if you're less than 40 and that total testosterone is less than 250, or you have some of the other symptoms you might be worried about in intracranial process to check it. But it has to be really, really low if you want to check it in older men. Even in men with secondary hypogonadism, the prevalence is so low that they haven't really been able to prove that MRI is cost effective. So I don't and we'll talk about my approach, but I don't routinely find myself doing MRIs. And so how do I treat? So the recommendations, I find these pictures online are always funny. This guy's really sad. And so the symptomatic men, so the recommendations from the guidelines say improve sexual function, improve sense of well-being, improve muscle mass and strength, and improve bone mineral density. So I think that those are kind of vague, so we'll try to tackle some of those issues. The other thing is, who should I not treat? So some specific recommendations that they give, so history of breast or prostate cancer. It's a little bit nebulous in your patient that's had their prostate removed. I shared a patient in my previous job with a radiation oncologist. The patient had really low testosterone because he had his prostate removed and was really convinced his quality of life was terrible because he didn't. So we decided to treat with close monitoring. And that went well. Of course, I'm gone, so who knows what happened. But patients with hematocrit more than 50%, so we worry about erythrocytosis. We'll talk about that later. Severe untreated sleep apnea. If they have severe sleep apnea or on CPAP, it's okay. Severe lower urinary tract symptoms or poorly controlled heart failure. So the heart failure thing, they're worried about fluid retention with testosterone therapy. And then use in caution with patients with prostate nodule and elevated PSA, or PSA more than 3 with men are at high risk for prostate cancer. So they consider those African Americans or people with first degree relative with prostate cancer. So maybe not be good candidates in this list. So what are the options? So there's a lot of options. These are the ones that are the most readily available at this point in time. So one is an injection. So that's either weekly or every 2 weeks. There's topical gels out there, 1 or 1.62%. A daily application they rub on their upper back, usually a transdermal patch, and then some oral adhesive tablets. We'll talk about some of those. And so a lot of stuff out there about I get asked questions a lot about these testosterone boosters. They have studied some of these, and nothing has ever really shown, as you would expect, to increase testosterone. But apparently, there's no end to the number of those that are out there. So what are some of the pros and cons? We'll talk about some of these. So the injection. So usually I find myself, if I do this, testosterone cypionate. So it's inexpensive. It's pretty quickly effective. People notice an effect pretty quickly. But they do get peaks and troughs, kind of like that first guy that I talked about. And so they'll feel great for a while, and then it generally will go back. The levels will usually be subnormal prior to the next time they have an injection. And then obviously the challenges of giving yourself an injection. Topical gel, so it's easy to use. Patients generally tolerate it pretty well. Take a shower, rub it on their shoulders, cover themselves up with a shirt. It is usually pretty expensive, and there can be transfer of medication. So they recommend only rubbing it on areas you can cover with clothing. You can transfer to children or women. One of my favorite things from the Axeron is put it in your armpit. On the webpage, that's the thing that says Axeron is flammable until dry. So let it dry before smoking or going near an open flame. So I wasn't aware. I've never ordered that, but I wasn't aware of that until I got on actually their own website. The patch is pretty easy, but a pretty high likelihood or pretty high incidence of dermatitis. And these buccal tablets are really only helpful really only approved in young men. I've never tried to order those before. And so how do you monitor? So the monitoring, generally, you're trying to get their total testosterone into what's considered the mid-normal range for a young man, and that's what the lab assay tells us. It's like the normal values for a young man, usually less than 40. Monitoring hematocrit, PSA, DRE at baseline, and then maybe at 3 or 6 months, and then they give you some indication of when to stop. So if the hematocrit is going up, the PSA is rising. If you find a new abnormality on your prostate exam, or if their lower urinary tract symptoms are getting worse, there's the most recent guidelines from 2010, so there's some talk about PSA velocity in there if you've been following a PSA for at least 2 years, which may not be as applicable anymore. And then reassess their testosterone and the response in 3 to 6 months. So if you're repeating their labs, if you do an injection, then they need to check it at the halfway point. So if they do it every 2 weeks, they need to check it after a week, or else it's potentially misleading how effective it is. The patches, you can see in 3 to 12 hours. If you use the buccal tablets, then you can use it immediately. And then the topical gels anytime they've been on therapy for a week. And so what other interactions? So if warfarin is always a concern, so it actually can potentiate the anticoagulant effect of vitamin K agonists. I find that interesting for reasons we'll see later. It may alter your insulin sensitivity, might actually improve it. So sometimes people will need less. You need less, less medication. And then glucocorticoids may result in significant fluid retention. And so the other thing is, so what about the black box warnings? So this one, I think 2014, 2015, they made some updates about increased risk of heart attack and stroke for men who take testosterone. Lots of conflicting data out there. And so the people who don't agree with this will say, the data is incomplete and misleading. And so this is kind of case in point, three different studies. So the first one is an observational trial in the VA. They took 1,000 men with low testosterone. They treated 400 of them, followed them for 3 years, and found that they had a reduced overall mortality. And then the second trial, the second one down, was a meta-analysis of 51 trials. 7 of those trials had cardiovascular outcomes, and they followed to see it. And they had no change in cardiovascular outcomes. They had 0 effect. And then this study, the last one in the bottom, is from the New England Journal, obviously in 2010. And so they actually stopped this trial early for an increased risk of cardiovascular events. Now, those events were self-reported, and I put this table up here, and a lot of them are, some of them, acute coronary syndrome, yeah, but so a couple of syncope, some leg swelling, self-reported syncope, leg swelling, elevated blood pressures, those kind of things. So whether that's truly, it's probably, a lot of them are not major adverse cardiac events, but they were considered cardiac events for the purpose of this study, and so it stopped after 6 months. So I think there's a lot of uncertainty in terms of the cardiovascular risk. And so the other one is for blood clots. So there was talk about these products increasing people's risk of venous thromboembolism. And a lot of that's from post-marketing surveillance and some case reports. So a couple of things that I found interesting. One was in August of 2015, in the Mayo Clinic proceedings, obviously one of the journals you start getting for free in your mailbox out of nowhere. But they did a case-controlled study. Obviously, there's yet evidence-based medicine limitations there, but what they followed 30,000 men over the age of 40, and they say that receiving testosterone within 15 days was not associated with the risk of VTE. That wasn't necessarily always people who were treated with testosterone. There is wording in there that says having a prescription filled for testosterone. So we're not exactly sure how many of those patients actually took the medication. And then another study out of Cincinnati, they followed, I forget how many people, found 42 cases of clots with people who were on testosterone. They checked a bunch of clotting factors and some other things, and found that a lot of them had undiagnosed what they call thrombophilia or hypofibrinolysis. I've never done quite such an evaluation. And so what they recommended from that study was considering checking people who either had a personal history or maybe a family history for some inherited thrombophilia before you would start. That's not found its way into any sort of major recommendation thus far. So I'm going to talk about a little bit about some of the things I see where people come in and talk about. So low testosterone in ED seems logical, and for patients it seems to make sense. I found it interesting, actually, like choosing wisely about testosterone. And some of the data that's out there largely not really, with people who have normal testosterone, to give them testosterone, they have ED, it's not going to help. And so they're probably not helpful as well for men who have low testosterone. The only thing they're complaining about is erectile dysfunction. It's probably not going to help. It might be helpful in improving their libido if they complain about that. Some of the newer information, and this is from the International Journal of Impotence Research. There's journals for everything these days. So for those patients with ED, if they got ED and they got a PDE5 inhibitor, if their testosterone was really, really low, they seem to think that there was some benefit in erectile dysfunction for people with who have low testosterone or were treated with testosterone replacement. We're pretty confident that we know that low testosterone can affect bone mineral density, or at least that's something that we typically talk about pretty frequently. There's actually very few studies that will bear that out. The evidence is pretty inconclusive. This study that they did, this was from Archives of Internal Medicine in 1996. They actually, this is very small. They took 15 or 20 asthmatic patients who were on glucocorticoids and chronic oral glucocorticoids, and they put them on testosterone and followed them for a period of 6 months, and found that they had maybe some improved bone mineral density and reduction in markers of bone turnover, but the clinical significance was really uncertain. And they don't really recommend, obviously, testosterone might be an adjunct for the right male patient who has low bone mineral density, or possibly the person who's on chronic glucocorticoids. That's the nature of that study, but bisphosphonate therapy would still be first line. They've done some studies about low testosterone and cognition. We talked about mood, depression, things like that, but no studies really demonstrate significant improvement for low testosterone, for treating testosterone and improving your cognition that I can find. And then the other thing I think is interesting too, so the American Diabetes Association has a statement that says that men with diabetes are twice as likely to have low testosterone. Probably a lot of confounders there, obesity, any number of other things. A couple of studies from Diabetes Care. So this study earlier this year showed that improved insulin sensitivity and might decrease overall adiposity. At what, what's the clinical significance? We're not necessarily entirely sure. In a small trial in Europe where they treated people with testosterone for 6 to 12 months and found reduction in or improved insulin resistance and glycemic control, reduced cholesterol, and then visceral adiposity. And what they said was, since we're improving all these risk factors, we're probably potentially reducing overall cardiovascular risk. But again, none of these things haven't necessarily found their way into any widespread kind of guidelines. And the other thing too is the low testosterone in the elderly. So testosterone levels, we know they fall. We don't know if it's pathologic or not. And so how beneficial testosterone is, we just really don't know. One recent trial that came out this year in the New England Journal, they actually screened 51,000 men to find 790 of them that they could put through this trial. So it had 3 different groups: a sexual function group, a physical function group, and a vitality group. So they had low T and they had some of these classic symptoms. And so they were put on treatment. Moderate benefit on sexual function, that's usually more just interest more than it is any sort of improvement in their performance per se. Maybe some benefit on mood, but interestingly, no benefit on vitality or walking distance. I read some other smaller trials I didn't put in here, but there was one in 2009 in an endocrine journal of Clinical Endocrinology and Metabolism, where they took frail elders and they treated them for 6 months and found they had improved muscle mass and strength. But again, there was no long-term follow-up or long-term endpoints for those people. In general, the recommendations are not to treat the elderly if they don't have any other additional symptoms, if they just have age-related drop in low testosterone. So that was a kind of a quick overview to go back to these kind of these quick cases. So this first person that I saw who he felt like he was very dependent upon his testosterone. And so I told him that I really wanted to know if it was low or not. So first thing I did was just wean him off of his prednisone completely. I got him in with a new sleep doctor and made him be compliant with his CPAP medicine or with CPAP machine and waited. So I brought him back initially after he'd been off the prednisone for about a month. We checked labs. His testosterone was still pretty low. I did some of the other. I checked his thyroid, I checked his iron, checked all these other things. He had existing hypothyroidism, but he was used thyroid with his labs and everything. And so then I waited another 3 months. I don't know. I couldn't find anything that said, here's how long you have to wait. He wasn't happy about it. For all I know, he could have been going home and taking leftover testosterone, but I waited another 3 months and he was still low. And so with his age and his testosterone was like in the 120s. And so I did send him for an MRI that was normal. He had 5 children. He had no issues with infertility. And then when I saw him back again, I was like, are you sure you haven't done anything else? So at one point in time, he was on chronic opioids, he was on chronic prednisone. And so those were the reasons that he probably had low testosterone. Then I became less confident. I sent him to endocrinology, and they agreed. So I went ahead for him because he felt so poorly. I said, at least temporarily, maybe we can try to increase your testosterone levels. You can make some significant lifestyle changes, and maybe we can take it away at a later date. He hasn't followed up. But he kind of has that tendency to not follow up. But the second one, I just offered him some reassurance that this was probably just related to getting older and that I didn't really feel like I could help him by putting him on testosterone therapy. He and his wife were not routinely sexually active anymore. He felt like that wasn't a part of his life. For a healthy 76-year-old, if he would have, he used Viagra occasionally, but it really was maybe like on a couple of occasions a year. If that would have been something that he might have been suffering from, I think that he could have argued that maybe he could treat him safely. And then maybe if you find that right, like I mentioned that talk about frail elders, maybe if you were trying to improve his functionality for a short period of time, that might be something to consider. I don't know if there's any good geriatric literature about anything like that. And then the last one, and so this one I think is potentially more compelling. So we saw some of the diabetes data. for him, I really, I sort of kind of made a bargain. I said, okay, well, we can check your low. I told him we could check it, but I can tell you what I would blame it on if it's low. You're obese, and you have some of these other potential risk factors. And so we worked on kind of an exercise and diet plan and kind of targeted weight loss and targeted, reduction in his A1C. And so that's where we stand at this point. I'm considering, after I've learned more about maybe for a short time, if his testosterone is low and he's done these things, about putting him on it for a short time, and can he make some of these lifestyle changes and get to where we want him? Can we take it away later? I haven't decided. He's still in the mix. I just saw him a few days ago. So kind of briefly in summary, I guess I could have told you at the beginning there's a lot of uncertainty and listed that. Patients are certainly bombarded with information in the media. Those supplements are making tens of millions of dollars each year. And same with the prescription testosterone. A lot of people are taking it, inappropriately. Treatment options exist, may be expensive and maybe not beneficial. You need to monitor them, and then maybe limited benefits in the elderly. So my general approach is I'm relatively stringent on those. I'll even test. And so I try to really dig down in their history, and then sometimes it's just to put it off, but I try to see what other things we can check for, what other things we can do before I'll even check. And that might be in the younger to middle age group. If they're 75 or they're 80, at this point in time, I don't generally do it. They're 55, they're 60, they're having sexual complaints, things like that, then I may be more inclined to maybe be a little bit more aggressive. They're not interested, they feel like it's affecting their marriage, those kind of things. You might consider screening those higher prevalence groups. I feel that list up, especially if they have more than one condition. They're obese, they're diabetic, they're having erectile dysfunction. And so without obvious reversible causes. I generally try to tell them up front that there's limited evidence and, we don't really know much about the benefits. And then I do require them to come in for regular monitoring, for labs and for rectal prostate exam and those kind of things. So that's the quick spiel. Hopefully less time if anyone has any questions or is interested in sharing their expertise or what they know about this topic. Thanks.
Thank you very much, Dr. Goist. Are there any questions either on the phone or in the room here? I'm going to gradually unmute everyone.
And if you're checking a free testosterone, do you also have to do that at 8 to 10 in the morning?
Yeah, so they recommend it. I think any of the levels of testosterone, they just recommend checking it somewhere between 8 and 10. I think that it starts peaking again. It's like the upward trend occurs at like 4 a.m. And so I think the 8 to 10 recommendation, I think, is largely based on they figure the lab is probably open at 8 o'clock in the morning. So probably anytime you can check at like 7 or whatever. But yeah, the current recommendation is to check it again in the morning.
Questions from folks on the phones now that you're all unmuted. Any other questions in the room? Great. Well, thank you very much, Dr. Goist, and thanks everyone for joining us.
Thanks.
Thank you.
Thanks. Close that window first.